Jen's rinsing for 2 1-minute intervals. And please, yeah. This is round 2. Jen is an awesome rinser.
Tell us a joke.
We're going to want 3 rinses per day for the next 3 days, basically, and then the dimples will be gone by then. All right. And we're super lucky to have Barbie as our dental assistant today. So 18 aligners total, and you're about number 9 right now? Okay, and you are on 2-week intervals presently?
Right.
Okay. Want to speed that up?
Yes.
Yes. Okay.
I said no.
Do you find by the end of the 2 weeks that they're feeling pretty passive and they're not doing much? Got it. Okay. So after the 3rd day, not much else. Is there ever another episode, maybe at about a week and a half or so, where you feel a kick again, or not really? Okay.
No.
Got it. All right. So with Dr. Rehal's permission, after we've micro-osteoperforated you, we'd like to shorten you up to 3-day intervals, and let's make this happen. Mm-hmm. Okay? Yeah? Is that okay? And we'll get you going on the vibration as well. 5 minutes per day for every day. Okay? Does this thing stop eventually?
Let's hope so.
So we generally look for teeth that we know are going to be particularly troublesome. If we're going to 3-day aligner intervals, sometimes we kind of mop the whole mouth. But generally focus in on teeth that we know are going to be most difficult. And in Jen's case, it's likely going to be the lower incisors and also the lower molars as well. And yeah, so here we go. So watermelon better than pina colada. Note to self.
Watermelon tastes like Jolly Ranchers.
Jolly Rancher, okay, good to know.
Well,
Awesome. And we generally prefer to go from the buccal. The exception would be, say, an impacted canine that we're trying to get mobilized, then we'll perforate on the palate. But if you recall that sort of diameter effect where it's 8 to 10 millimeters, you got to know that's in 3 dimensions. So it's going to go all the way around and onto the other side of the bone as well. Okay, so we got a little bit of anesthetic coming your way here. We generally want to avoid the mental foramen. So I'll sort of skip over and get to the anterior teeth. Prefer not to get into that area. Still okay?
Mm-hmm.
So on the lower anteriors, as I mentioned, we generally find the need to only have 1 perforation between each root. Towards the back, generally 2 in a nice little column and at least 2 millimeters apart. Patients that are on a lot of anti-inflammatory, it doesn't work well with them. And in particular, for the next few days, if Jen does have some pain, we're going to ask her to not use non-steroidal anti-inflammatories such as Advil or Aleve, but instead choose something in the acetaminophen family, such as Tylenol. And the idea is we actually want inflammation to occur, so that's a positive. And other patients we see trouble, and it's actually no matter how we're doing the orthodontics, is patients that are on bisphosphonates, as in osteoporosis patients where the drug is actually knocking out the osteoclast, so we're not getting the action that we want. I wouldn't use it in a pregnant person or anyone undergoing anything like radiotherapy or chemotherapy, of course. We would avoid it. But otherwise, it's pretty widely used, mostly in adults, of course. Kids, not as much needed, but in the kids, we use it mostly reactively when we run into teeth that just won't move. There we go. Okay. Any questions so far, you guys? We're good? So, of course, I'll just go around and make sure that she's not going to feel any of this. So, this is the device here. And the removable part is this. So this is the disposable part, and this is the reusable part, which is autoclavable and can be used multiple times. This is disposed of as a sharp, of course.
How many holes can you drill with that one?
Generally, 1 mouth worth. So however many you're doing, and then it's disposed of. Some people say, could I save it? I'm going to do it again in 12 weeks. And the answer is no, you shouldn't do that. Yeah. So we take off its little protective cover, and you can see the sheath here, which has the graduations on it for the various depths. So as this thing goes in, the sheath retracts and exposes the screw. And as it hits the blue shell, that's how deep you're going. So it's 3, 5, 7 millimeters of perforation. Generally in the front, I'm going in 3, so that's actually accounts for 1.5 millimeters likely of soft tissue, and then another 1.5 millimeters to get through the cortical bone and into the cancellous bone. In the posterior, a little closer to 5 usually, and in the palate, closer to 7. Okay, so we're gonna get this to go, and let me know if I'm bothering you or if you need a break. Okay. And you're sitting on your hands. It's good. Okay. Do you want to grab my tie? All right. So just sort of retract. You can actually have the patient close their mouth. This thing is pretty well straight on at 90 degrees. So we want to try and not irritate the commissure of their mouth. If she's a little frozen, she won't be able to tell you that. So let's start here, where we can really see it. So this is between the premolar and the molar here, and I'm going to go, as I mentioned, quite high to start. And so she'll feel it engage like that, and then we start turning it, and it's tidy ready, of course, so turned in a clockwise direction. Still okay? Mm-hmm. Yeah. And I'm putting pretty good pressure on it with my hand. You saw Dr. Shipley in the video. He was putting pressure with his thumb on the head of the handpiece as well. So there, I'm in 5 millimeters right there. Also to about 5 millimeters. And make sure we're all the way here. We're expanding here, so I actually want to go further back. Do you feel that at all? Mm-mm. No, you're good? Okay, thank you. Either she's frozen or just being very brave for the camera at this moment. And you can actually feel it. You will feel when you're in soft tissue, you'll feel when you're in cortical bone, which is quite hard, and then you'll feel it go in to the cancellous bone, and it's much easier going. And you only need to be like a millimeter and a bit into the cancellous bone, and then it's going to do its thing. Okay, so a little tougher, and I'm actually pushing fairly hard here. Mm-hmm. And now I'm through. Mm-hmm. I can feel it. And you may be able to feel it a bit too, Jen. Mm-hmm. Yeah. Mm-hmm. Okay, so I'm going to stop there, back it out. So once again, this is just infiltration. We haven't blocked her, so she might feel it a tiny bit. So you can see the sheath is nice. There's a version of this without the little sheath on it. It's just an open screw. Mm-hmm. But I can't really tell how deep I am, or not as accurately anyway.
The motorized one doesn't have a sheath.
It does not, no. You're right. And this one we don't want to go as deep. There's only a couple of millimeters worth here that you have to go in. And we want to get as close to 90 degrees as we can. That's why the handpiece is nice for the posteriors, because it has a contra angle on it, and it's a little less of a direct hit here. Still good? Mm-hmm. And, okay, no, I think we're done. Yay! Jenny, you are awesome. Awesome.
Good job, Jenny. Don't make me smile.
So how was that experience?
Terrifying, but it was okay.
Okay. You did great. Thank you. All right? Good? Okay.